Om Swastiastu. First of all, thank you for the time, and with highest praises and thanks to Almighty God who has given us His gracious mercy so that we can do our presentation. So we are from small group discussion B3. We will do our presentation with the topic Clostridium difficile infection. So these are the members of small group discussion B3. The first material will be explained by my colleague.
Firstly, let me introduce myself. My name is Arya with 3 last digit name 089. Basically, Clostridium difficile or C. difficile is a toxin-producing, gram-positive anaerobic basal-shaped bacteria that form spores. There are some possible reservoirs for C. difficile, such as carriers who are asymptomatic, sick patients, contaminated environment, and the animal digestive system. CDI has been discovered as a leading source of nosocomial infection in hospitals, with the majority of cases occurring in industrialized countries. And in 2002, C. difficile B1, BINAP1, 0 to 7 clones first identified. This strain also produces a binary toxin called C. difficile transferase, which is also produced by other strains such as ribotype 078 and 023. The incidence of CDI has decreased in some region of Western Europe, remains in North America, and spreading to Eastern Europe. While in Australia, there's ribotype 244, but BINAP1027 clones has yet to be established. And in Asia, it is dominated by non-binary toxins such as ribotypes 017, 018, and 014. From 2007 until now, the prevalence of C. difficile BINAP1 0 to 7 has significantly declined. And in our country, in 1993, 6 out of 8 healthy patients were AB+, and 6 years later, toxin EIA was found to have prevalence of 1.3%. That's all from me. Next slide will be presented by my colleague. Thank you.
Hello, my name is Dewa Guptha with the last 3 digits of name 072. So right now, the first one is that I'm trying to explain about the formulation of this literature. There are 3 points. The first one is that what is the Clostridium difficile and its origin. The second one is that what is the pathogenesis, etiology, and clinical manifestations of Clostridium difficile infection. And then the last one is that what is the prevention and treatment of Clostridium difficile infections. And then for the next chapter is that what is the objective of this literature. So we have 3 points here. The first one is that the understanding the Clostridium difficile definition and its origin. And then the second one is that the understanding the etiology, pathogenesis, and clinical manifestation of Clostridium difficile infection. And then the last one is that the understanding the prevention and treatment of Clostridium difficile infections. And then we move on into our benefits is that we provide the information about the bacteria, Clostridium difficile. The second one is that we provide the information about the disease of that caused by the Clostridium difficile. And then we also provide the current information about the treatment and prevention of Clostridium difficile infections. And then we believe in the future we can make the future improvement regarding the prevention and the treatment for the Clostridium difficile infections. That's all from me. Thank you for the time.
My name is Komang Wahyu Widya with the last 3 digits of name 086. Today I'm going to talk about the properties of Clostridium difficile. It was found out in 1978 that Clostridium difficile was the #1 cause of antibiotic-associated diarrhea and colitis. Complications of this disease can increase from severe and even fatal. It has become a major public health threat since then. Understanding Clostridium difficile from a microbiology standpoint will aid in better understanding of the disease itself. In the general structure, Clostridium difficile have external appendages, which are type 4 pili and flagella, and also has surface layer or S layer. Clostridium difficile also have cell envelope, which includes cell wall and cell membrane. Cell wall made of peptidoglycan and secondary cell wall made of polysaccharide, which are 3 types: polysaccharide 1, polysaccharide 2, and polysaccharide 3. As a usual bacteria, Clostridium difficile also have internal components which are cytoplasmic matrix, ribosome, inclusion, nucleoid, and actin cytoskeleton.
My name is Dewa Naraswari Mesi with 3 last digit of name 074. I will explain about the classification of Clostridium difficile. As Cross Morales et al. Said in 2019, Taxonomy is the classification, identification, and nomenclature of the organism scientifically. The taxonomy of Clostridium difficile will be explained based on the table below. The domain is bacteria. Bacteria are a single-celled, non-nucleus, and non-membrane bound organelles. The phylum is Firmicutes. Firmicutes are a phylum of bacteria which have round rod-like forms or round cells. The class is Clostridia. Clostridia are a genus of spore-forming, rod-shaped, and gram-positive bacteria. The order is Clostridiales. This is a group of organisms that might be gram-positive or gram-negative, and it can be a pathogenic and included in free-living organisms. The family is Clostridiaceae. Clostridiaceae is a family of anaerobic and gram-positive bacteria that are usually characterized by the formation of spores and contain mesodiaminopimelic acid in peptidoglycans. The genus is Clostridium. Clostridium are a large genus of Firmicutes, which is an obligate anaerobic and gram-positive bacteria. The species is Clostridium difficile. Clostridium difficile is a causative agent of antibiotic-associated diarrhea caused by healthcare providers and the general population, and can lead to patient morbidity and mortality.
My name is Nyoman Sri with your last digit of NIM 084.
Next one is about characteristic of Clostridium difficile. Clostridium difficile is one of the members of Clostridiaceae family. This bacteria is an anaerobic bacteria, or a bacteria that is very sensitive to even low levels of oxygen in the environment. Its shape is bacillus with gram-positive cell wall. Clostridium difficile are composed by outer and inner component. The outer component composed by peptidoglycan and secondary cell wall polysaccharides, and the inner component composed by cytoplasmic matrix, ribosome, inclusion, nucleoid, and also actin cytoskeleton. The natural domain of this bacteria is soil, and a few kinds have adjusted itself to occupy the stomach via fecal-oral pathway, contaminated food, mediators, or hands. Clostridium difficile can form spore and toxin. The infectious of Clostridium difficile is especially mediated through exotoxin, which include toxin A and toxin B. Toxin A causes excessive water secretion, stimulates an inflammatory response, and bind to receptor sites on the brush border membrane of the intestine. And the toxin B is a formidable cytotoxin.
My name is Aurelia with the last three digit name is 081. I will explain about the definition of Clostridium difficile infection. Clostridium difficile in spores infect feces, and the pathogen is commonly found in the environment. The history of Clostridium difficile infection has been changing since the last 10 years. Potential reservoirs for CDI include asymptomatic carriers, infected patients, contaminated environments, and the intestinal tract of animals. CDI is now one of the most important nosocomial infections affecting all aspects.
Alright, my name is Gede Arya Dhananjaya, and at this moment, I would like to talk about the etiology of Clostridium difficile infection. The agent factor of Clostridium difficile infection is the rod-negative gram bacteria named Clostridium difficile that can produce spores and toxin while infecting the host by damaging intestinal endothelial cell. Clostridium difficile infection incidence can be exacerbated by some risk factor from the host and environment, such as lack of antibody response of Clostridium difficile toxin, history of previous therapy that may include high-risk antibiotics, for example, the fluoroquinolones and second generation of cephalosporin, and previous hospitalization factor. This risk factor cause Clostridium difficile infection to be termed as hard care or antibiotic-associated diarrhea. Okay, that's all from me, and the next topic will be explained by my colleague.
My name is Ibu Dharmayuda with last three digit number 083. The pathogenesis of Clostridium difficile infection. Most Clostridium difficile infection or CDI are caused by spore transmission. Regular microflora is the main barrier to CDI. Dysbiosis or destruction of the host endogenous creates an excellent environment for CDI to develop. Its pathogenicity is primarily due to its toxin A, B, and CDT. Clostridium difficile produces a toxin known as a binary toxin or Clostridium difficile transferase. The lipoprotein receptor split by lipolysis is the cellular receptor for CDT. Ribosylation prevents the polymerization of the submembrane network and results in increased fibronectin transport to the cell process and cell surface created by microtubule, thereby increasing the attach of C difficile to the target cell. Digit A and B have RHO and RAC glucosyl triphosphate domain at the amino terminus and cause toxicity by glycosylation and inactivation of the host RHO and RAC GTPase in the cytosol of the target cell. This destroys the cytoskeleton, leading to disruption of the tight junction between colonic cell and loss of epithelial integrity. Loss of epithelial integrity leads to increased intestinal permeability and bacterial migration from the intestinal lumen to deeper tissue. In response, resistant and toxic epithelial cells release inflammatory cytokine and chemokine, mobilize circulating innate and adaptive immune cells to express antibacterial response.
My name is Sutedja with the last 3-digit name 080. I will explain about clinical manifestations of Clostridium difficile infection. Most of the manifestation relates to gastrointestinal functions, which include diarrhea. In the Bristol stool chart, this would be 5 or 6 or 7, and then frequent excretion more than 3 times a day, and then blood or mucus and feces. This may be not visible to the naked eye. Next, other possible manifestations are fever, hypotension, shock, dehydration, unbalanced electrolyte levels, hypoalbuminemia, and then acute distension of colon, perforated bowel, renal failure, sepsis, fulminant colitis, which can lead to death if left untreated. And some rare manifestations are arthritis, bacteremia, and inflammation of ileal lining and pouch. Thank you.
My name is Aisyah Taqiyyaa with 3 last identity number is 076. So these are the prevention of Clostridium difficile infection. Hospital-based infection control that able to alleviate the incidence of CDI depending on its stage. In case where there is of CDI, readers are recommended to use antibiotics that work shifts, glove use, keep the hand hygiene by always washing hand after touch things, a combination between probiotic and prebiotic. Disposable thermometer should be used routinely, using Bacillus calcii as a bacterial which secreted components to neutralize Clostridium difficile toxins, and certain bacteria produce an antibacterial compound that are able to direct inhibition of Clostridium difficile. That's all for me, thank you.
My name is Gregory Sulamtongratama with 3 last digit name 085. Now, I'm going to explain about the diagnosis and treatment of Clostridium difficile infection. Someone should be suspected to suffer this infection if possess some signs, like to severe diarrhea, gross lesion of bowel and ileus. Radiographs show symptoms that lead to toxic megacolon, like pseudomembranous colitis or nohostra in descending colon. For further examination could be performed enzyme immunoassays for glutamate dehydrogenase, enzyme immunoassays for toxins A and B, cytotoxicity assays, toxic culture, and nucleic acid amplification tests. Frequently used medication for this infection are vancomycin and fidaxomicin. The dosing of those antibiotics are based on the patient's condition, but for subsequent recurrence, need fecal microbiota transplantation. That's all from me. The next presentation will be continued by my colleague.
My name is Indiarwan Anantaseno with last 3-digit name 091, and the conclusion of our studies are Clostridium difficile is a Bacillus gram-positive anaerobic bacteria covered with capsule and can move freely with prestigious flagell. Clostridium difficile transmitted through fecal-oral with spores, and the spores are resistant to the heat, acid, and antibiotics. And CDI or Clostridium difficile infection could produce toxin while infecting the host by damaging the endothelial cell. The virulent factor is primarily due to enzymes such as collagenase, hyaluronidase, and chondroitin sulfatase, and of course toxin. The virulence factor could cause disruptions in tight junction, fluid secretion, neutrophil adhesion, and local inflammation. The clinical manifestation usually relates to gastrointestinal function and also affect the whole body. Clostridium difficile infection could be prevented with hospital-based infection control, antibiotic stewardship, and many more. The treatment is doing antibacterial therapy for CDI, vancomycin, and fidamycin.
My name is Guptha with my last 3 digits of name is 087. Clostridium difficile infection is one of the most common nosocomial infection require further attention in handling. Water suggests improvement in further research about this infection as an effort to maximize patient care, such as optimization in the accuracy of diagnostic tests and diagnostic test algorithm. Better prevention and treatment of patients is also needed to their importance. Authors hope this paper could give useful information to the readers. We realize that this paper is therefore from perfect, therefore we hope for constructive criticism and advice to improve our paper.
Okay, that's all for our presentation. Thank you for the time and thank you for the attention. Om Santi 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 Om.